Oh, we're back on recording. Allow me to welcome our panelist and moderator for today. His name is Dr. William. He is a medical doctor with 8 years experience in healthcare and healthcare management. He has worked at AIC Kijabe, County Government of Siaya, and AAR Healthcare as a general practitioner. He also has 5 years experience, 5 years plus experience in the pharmaceutical industry, and has worked in medical affairs department of 3 of the leading global pharmaceutical organizations. He is passionate about non-communicable diseases such as diabetes, mellitus, and how to use medical education to ensure good.
Hello, Mr. Mbao, can you hear me?
Yes, I can hear you loud and clear.
Thank you. I think I lost you for a minute there.
It's okay. It's okay, Daktari. I now give over this chance to you, Daktari. Take us through today's webcast. Asante sana, Daktari. Thank you.
Thank you so much, and thank you for having us. We are happy to be here as Novo Nordisk and to support this learning initiative, which we believe will actually add value to all those people in healthcare currently attending this session. Today's topic is very interesting. The field of diabetes has seen a lot of growth in terms of medication as well as research that has changed the practice fundamentally and very extensively too. And so we've had new medication coming up, and we've had new strategies for treating patients also being developed using the evidence-based studies that have emerged over the last few years. And today it gives me great pleasure to introduce Dr. Nduku Kiko. She's a consultant, a physician and endocrinologist currently working at Kenyatta National Hospital. She runs the endocrinology, the diabetes and the medical outpatient clinics at KNH. Dr. Nduku is well educated with a master's and postgraduate diploma in endocrinology from the University of South Wales and a postgraduate diploma at Cardiff University. This is in addition to her master's in internal medicine from the Aga Khan University and her bachelor's of medicine degree from UAN. Dr. Nduku has also had a stint in terms of teaching and supervising postgraduate and undergraduate students. And so she will make good of her lecturing skills for today. So without further ado, I'd want to introduce Dr. Nduku and hand over to her. Thank you so much. And I hope everyone will learn a lot from this session today.
Thank you so much, Dr. William Biko. I don't know if you can hear me. We are together?
Yes, we can hear you perfectly.
Okay, so I'm deeply honored to be talking about the treatment options in diabetes mellitus. This is a topic that is very key to my practice and to my work in Kenyatta. I run the diabetes clinic there together with many other endocrinologists, and I'm pleased to be with you today. So without much ado, we can go ahead and look at the treatment options in diabetes. Yeah, so the objectives of today's discussion will be to look at the epidemiology of diabetes within our local context, as well as in sub-Saharan Africa, and then look at also important diabetes terminology and the physiology of glycemic control, particularly as it pertains to the treatment pharmacology. And then the meat of the discussion will be on the treatment options in diabetes. So we agree that diabetes is a rapidly growing social challenge worldwide, and there has been an increase in the prevalence of diabetes. Looking at the previous International Diabetes Federation Atlas is all the way as early as 2011, where we had 285 million adults with diabetes worldwide. This has grown tremendously to the 2019 figures of 463 million adults with diabetes, projected to increase by 51% to 700 million by the year 2045. So this is a growing number that will require appropriate care to prevent complications from the same. Now, as we look at these large numbers, almost 80% of these patients live in low and middle-income countries. Looking at the IDF Atlas 2019, our countries listed in the group that have between 500,000 to 1 million. The prevalence is about 3.3%. So these are large numbers of adults with diabetes that we are talking about. This is a great challenge. Looking at Africa, the 2019 IDF data, we are talking about 19.4 million adults having diabetes, and this is expected to grow to 28.6 million adults by 2030, to 47 million adults by 2045. And the challenges that we are experiencing are great, both in diagnosis, ensuring appropriate care, and preventing complications. 60% of adults with type 2 diabetes actually do not know that they have type 2 diabetes. And over 300,000 died of diabetes-related causes as per 2019 IDF Atlas data. So there is the role of hubs that look at the challenges that we experience when offering care to our patients with diabetes. Of the 19.4 million with diabetes, only 40% actually are diagnosed, and half of that are receiving care, 4.1 million. Of that, about a third are actually receiving, achieving their targets. We look at the HbA1c targets that we're talking about, and only half of that avoid complications, whether it's the microvascular or macrovascular complications. So these are major hurdles that must be overcome to be able to get successful control of diabetes. So for the patient living with diabetes, it can have a very big impact on their lives in terms of the issues they report. 2/3 say there's a reduction in physical health from the diabetes, their financial impact in almost half, as well as reduced emotional well-being, stress, diabetic distress from the diabetes. It impacts leisure activities as well as work and studies in just about a third of the patients. And a fifth of them say diabetes has an impact on their relationships as well, relationships with family, as well as friends and peers. So as we try and bring diabetes under control in the treatment, our treatment is based on the pathophysiology of diabetes. So we'll have a look at that. Within the last decade, there's been a lot of talk on the ominous octet, which is the paradigm of the major pathophysiological basis that bring about diabetes, in particular type 2 diabetes. These 8 issues are an impairment in insulin secretion, decrease in incretin effect, which we'll look at, an increase in lipolysis, so the adipose tissue, decrease in glucose absorption at the level of the kidney, increase in glucose absorption at the level of the kidney, muscular effects in terms of insulin resistance at the level of the muscle with reduced glucose uptake, and then neurological effects with increased neurotransmitter dysfunction and hepatic effects such as increased hepatic glucose production. Within the last few years, this ominous octet has actually grown by about 3 other factors, including the immune zone response, the second one being gut microbiome, and then local pancreatic effects such as low amylin. So as we understand diabetes better, we get to tailor our treatment better to be able to achieve our goals in management of these patients. Hi, we are together, William? Yes, okay. So looking at insulin with a focus of normal physiology, when there is intake of food and absorption of glucose at the level of the pancreas, the glucose in circulation is taken up by the GLUT2 receptors, and this is further broken down through glucokinase and other pathways to release ATP, which causes a cascade of events that leads to insulin release at the beta pancreas cells. This is released into the portal circulation, and the hepatic effects of this are a suppression of hepatic glucose production, which is one of the major physiological effects of insulin that lower the blood glucose. Furthermore, within the systemic circulation, there are peripheral tissue effects of the insulin. At the level of the adipose tissue, there is uptake of glucose through, again, the Sglt2 receptors, as well as at the level of the muscle, there's also uptake of glucose through upregulation of the glucose receptors by insulin. So these issues at the level of the liver, adipose tissue, as well as muscle are impaired when we have insulin resistance as well as diabetes. Within diabetes mellitus, this is particularly looking at type 2 diabetes. There are studies that have been conducted over prolonged duration. And one of the major studies is the UK PDS study. And from this study, we were able to see that as early as 12 years prior to the onset of type 2 diabetes, there are alterations within the beta cell that predispose to the diabetes itself. And there is progressive decline in the beta cell function as early as 12 years before the onset of diabetes, as well as insulin resistance that is calculated through the HOMA models, homeostatic models. So there are phases, initially the levels of reduction in insulin, beta cell dysfunction and insulin resistance may not be high enough to peak. But as the disease progresses, there is worsening to the extent that this can be picked, for instance, through a glucose challenge, in which case we can say the patient has pre-diabetes, which progresses to diabetes with increase in the fasting as well as the prandial glucose, and then later to the later phases of diabetes. By the time you have the later phases, 10 years and beyond, this is a patient who may have complications that are coming in from the hyperglycemia. So looking at the same thing, there is progressive initially increase in the amount of insulin that can be released between the first 3 to 4 years. But this is trying to counter the upper blue line, the increase in insulin resistance. However, these compensatory mechanisms are not able to continue indefinitely. With time, due to systemic effects, such as the glucotoxicity, the effect of the high glucose, and lipotoxicity, the effect of elevated circulating free fatty acids, as well as the effect of circulating cytokines such as tumor necrosis factor alpha, we have progressive decline in the beta cell mass as well as the beta cell function with reduction in insulin, which brings us to the lower graphs that you're seeing, a rise in the postprandial glucose that can be picked from a glucose challenge, as well as a rise in the fasting glucose, initially reaching the pre-diabetes ranges, but as time progresses, it reaches the levels that would be in keeping with a diagnosis of diabetes mellitus. Our goal as we address diabetes is to improve glucose control so that we reduce the risk of long-term complications. Every 1% reduction in the glycated hemoglobin can reduce the long-term complications. We see a reduction in over 40% in terms of peripheral artery disease as well as amputation. This is data from UK PDS with every drop in HbA1c by 1%. For the microvascular complications such as retinopathy and nephropathy, there is a decrease by 37%, about a third of the complications with 1% decrease in HbA1c. And for the macrovascular complications such as myocardial infarction, as well as stroke, the decline in complications is 12 to 14% with every 1% drop in HbA1c. So as we try and address the various treatment options, our goal is to ensure that the patients that we are treating reach target and we can reduce the long-term complications. Without further ado, we can look at the various treatment options and how they work. Then we'll be able to see the various guidelines and where each of these drugs fall in place. Metformin is one of the drugs that has stood the test of time and is the first line across all the major diabetes guidelines, except for the ESC, European Society of Cardiology guidelines. All the others give metformin as first line. And you can agree with me that how metformin works is through the activating the AMP kinase pathway, and its major hepatic effects through that pathway is to reduce the utility of the substrates for gluconeogenesis, such as glycerol, by inhibiting the enzymes that would be enabling glycerol use in gluconeogenesis, as well as other substrates like lactate, which may accumulate in terms of complications that we may get with metformin. And through that, reduce hepatic glucose production. Other than the effect on the liver, it also improves the sensitivity to insulin in other target organs, such as muscle, again, through the AMP kinase pathway, which improves sensitivity to insulin and reduces insulin resistance through the insulin receptor substrates, such as the P13 kinase pathway, subsequently leading to an improvement in protein synthesis within the muscle, cell growth, and proliferation. The concerns with metformin, despite it being first line, would be for patients who have renal dysfunction with a glomerular filtration rate that is below 30. For those, as per the International KDIGO, Kidney Association guidelines, we would stop metformin if the GFR is below 30. And if it is below 45, the dose of metformin is recommended to be at a half. For those whose GFR is above 45, the dose of metformin can continue with monitoring of the renal function. The other concern with metformin would be vitamin B12 levels. For those who've been on metformin for more than 4 years, the recommendation is that in the presence of symptoms of deficiency, or at least annually, the levels should be monitored. So metformin, from previous studies that have been done a long time ago, UKPDS shows benefit with long duration of follow-up for these patients. So it is one of the drugs that has stood the test of time and is still first line in our major guidelines. Sulfonylureas are used a lot, and especially in areas where the newer agents may not be available because of cost. The sulfonylureas that are used a lot in our setup include Glybenclaramide, Gliclazide, Glimepiride, as well as Glipizide, most of them second generation. The concerns with sulfonylurea is hypoglycemia, as well as concerns like weight gain. And particularly for patients with renal impairment, hypoglycemia becomes a major concern. So for instance, even for Glybenclaramide, even though we say that it can be a maximum dose of 20 milligrams, for most patients, this is a high dose. The concerns of hypoglycemia mean that for many of our patients, we may not go higher than 15 milligrams. And for Glimepiride, we may not go higher than 6 milligrams. So there is caution with particularly hypoglycemia. How do these drugs work? These are insulin secretory GOGs. Through their binding on the receptor within the potassium channel within the beta cell, they cause closure of this channel with depolarization and calcium influx into the cell that results in insulin release. An insulin release that is not glucose dependent and hence may cause hypoglycemia. The thiazolidinediones have also been around for long. In our current guidelines, they may not have much use except for areas where cost, again, of the newer agents may be an issue. We remember in 2007, the meta-analysis that portrayed that rosiglitazone had a higher risk of myocardial infarction. So the utility, especially for rosiglitazone that time, was reduced. These drugs, however, have made a comeback with studies such as RECORD showing rosiglitazone was not actually associated with increase in myocardial infarction, and pioglitazone, proactive study showing safety in myocardial infarction in terms of no increase in risk. So these drugs are used even in our current setup. Pioglitazone is used with a starting dose of 15 milligrams, maximum dose of 45 milligrams, with concerns, especially for patients who are at high risk of fluid retention. Patients who have heart failure, renal failure, these are not drugs that may be used in that setup because we agree that they may cause fluid retention and weight gain. So a lot of caution, particularly in renal, as well as heart and liver failure, which may be associated with fluid overload. These drugs are PPAR agonists, peroxisome proliferator alpha and gamma receptor agonists, and they reduce insulin resistance through these nuclear receptors. Hence, at the level of the adipose tissue, they promote glucose uptake as well as lipid uptake and storage and energy expenditure, reducing the levels of insulin resistance and glucose oxidation within muscle, and reduce hepatic glucose output through reduced gluconeogenesis, again through the hepatic nuclear receptors. Through the nuclear receptors as mentioned. There are other insulin secretagogues other than the sulfonylureas. These are the meglitinides. In our setup, we have rapaglinide, which is used particularly for patients who may have some element of renal dysfunction. Because it is cleared by the liver, rapaglinide may be used. The doses ranging from about 0.5 to 2 milligrams before each meals, given a short-acting form of insulin secretagogue with, again, because of the insulin release may cause hypoglycemia as well as weight gain, the anabolic effects of insulin. So they'd be cautioned with that. And they still have a role for patients, especially those who may not be in a position to use other agents, particularly in the case of rapaglinide with chronic kidney disease. So being insulin secretagogues, they work at the level of the beta cell. Their receptors are at the ATP-sensitive potassium channel. By binding on the receptor, they cause closure of the channel with depolarization of the cell, influx of calcium, and subsequently release of insulin. Alpha-glucosidase inhibitors, Acarbose is also a drug that is available. The doses ranging from 25 to 50 milligrams or even 100 milligrams. And they interfere with the absorption of complex polysaccharides. And because of their GIT effect, may cause flatulence as well as loose stool. So the side effects often do limit the utility of these agents. So as you can see, they interfere with the breakdown of the more complex polysaccharides to monosaccharides, hence interfering with their absorption. And subsequently, due to their local gastrointestinal effect, interfere with, they can reduce the sugars postprandially. Sglt2 inhibitors are drugs that have featured heavily in the more recent guidelines. These drugs reduce blood glucose by increasing the urinary glucose excretion. Their effect is entirely independent of beta cell function, so they usually will not cause hypoglycemia in the absence of other therapies that would cause hypoglycemia. So the agents that are available in our setup are dapagliflozin and empagliflozin as well as Cana. These drugs have featured heavily in the more recent guidelines because of the cardiovascular outcome trials that showed that these drugs have a role in particularly heart failure, reducing hospitalization in patients with heart failure, and also reducing progression of chronic kidney disease. In addition to that, reducing atherosclerotic cardiovascular disease, including myocardial infarction and ischemic stroke. This is seen from the major cardiovascular outcome trials such as CANVAS for canagliflozin, Declare-TINI for dapagliflozin, and EMPARAGE trial for empagliflozin. The challenge with the SGLT2 inhibitors is particularly for our patients who may have chronic kidney disease, with dapagliflozin and empagliflozin currently, as by FDA approval, not being recommended if the GFR is below if the GFR is below 45. So in advanced kidney disease, these drugs do not have a role because their glucose lowering effect is dependent on the kidney function. However, these drugs have a renal protective effect that has been seen in big trials such as DAPA-CKD and EMPA-Kidney. And for the renal protective effect, this benefit goes beyond the GFRs that we're talking about here of 45. So with time, we are hoping that they may be allowed at much lower GFRs below 45, but currently these are the levels of kidney function that these drugs may be used. The doses are as indicated: canagliflozin 100 to 300, dapagliflozin at 10 milligrams, and empagliflozin 10 to 25 milligrams. So how do these drugs work? Their effect is within the S1, S2 segments of the proximal tubule. By inhibiting the Sglt2 transporter, there is an increase in both glycosura and natriuresis, which causes a decline in blood glucose as well as lowering of blood pressure because of the natriuresis. This is indicated here at the level of the tubular lumen. They block the Sglt2, and so there is a reduced uptake of glucose at the level of the proximal tubule. The Sglt2 actually accounts for 90% of the renal glucose reabsorption. So this is the extent to which they block the reabsorption of glucose. The other 10% is accounted for by the Sglt1 within the S3 segment of the proximal tubule. So those Sglt2 are major agents in our guidelines, both nationally and internationally. We'll look at the guidelines in a short while. How about the glucagon-like GLP-1 receptor agonists, glucagon-like peptide-1 receptor agonists? These have a role also. They include liraglutide as well as exenatide. And we look at how these drugs work. The ones that are available locally are injectable. The oral GLP-1 are currently not available. So what happens with the glucagon-like peptide-1? In the presence of intake of a glucose load, as we talked about, there is the pancreas does respond to the presence of a glucose load within the small intestines and release insulin. However, within the intestinal mucosa, there are the L cells within the intestinal mucosa that are responsible for release of the glucagon-like peptides. These glucagon-like peptides have local effects on the pancreas to increase the amount of insulin that is released. In addition to the local effects on the pancreas, these glucagon-like receptors, the GLP-1, have other effects within the skeletal muscles to increase glucose uptake, within the kidney to promote natriuresis, and within the GI tract to reduce gastrointestinal motility so that you have less postprandial hyperglycemia, within the liver to promote glycogen storage, so there is increased glucose uptake. And then there are also neurological effect, neurotransmitter effect, and as well as other recognized neuroprotective effects such as an improvement in memory, and cardiac effects such as improvement of myocardial contractility and reducing ischemic-induced myocardial damages. So the GLP-1 agonists such as liraglutide and exenatide have evidence in cardiovascular outcome trials also in terms of reducing atherosclerotic cardiovascular disease. So these are newer agents that have had benefit within the recent decade. The GLP-1 are broken down by enzymes known as the DPP4, dipeptidyl peptidase 4. So the DPP4 inhibitors prolong the action of GLP-1, and that would be the mechanism of action which we will look at. We have Cetaglitin, vildagliptin, and linagliptin within that group. Sitagliptin, commonly used, has a starting dose of 50 milligrams a day. In the presence of GFR below 30, we use it at 25 milligrams. Maximum dose is up to 100 milligrams and may cause nasopharyngitis. Vildagliptin may cause a hepatic enzyme elevation, though not commonly. Linagliptin has quite some space, particularly in patients with renal impairment due to its hepatic clearance. So the mechanism of action of the DPP4 inhibitors, as we said, is by inhibiting the enzyme that inactivates GLP-1. So they inhibit the breakdown of glucagon-like peptide-1, hence prolonging the action of GLP-1. And we agreed that GLP-1 stimulates insulin release as well as suppresses glucagon secretion and has other gastric effects such as slowing gastric motility and hepatic effects, neurotransmitter effects. So they basically act by prolonging the GLP-1 and inhibiting its breakdown, by inhibiting the enzyme that breaks it down. So the classes of drugs we are looked at are extensive, and they address the ominous octet by decreasing, they're looking at the various agents, whether it's at the level of the beta cell, the alpha cell, muscular effects, adipose, renal effects, gastrointestinal effects. These groups of drugs are basically addressing the various targets within the ominous octet to reduce the levels of hyperglycemia that are present in diabetes. What about insulin? Insulin is available as basal insulin, which may be the human or analogs as basal. By analogs, we're talking about glargine, we're talking about detemir and degludec. And then there are premixed insulin again, which may be the human premixed or the analog premixed. Rapid-acting insulin, which are the analogs with the short-acting being the human soluble insulin. The rapid-acting analogs include glulicin and lispro and aspart. Then there are combinations. There are some that may be a combination of the various, for instance, a basal bolus, which would have basal as how do these basal insulins work? These are injected and they are able to be released. Form hexamers within the subcutaneous, so they have a depot within the subcutaneous tissue and
Dr. William?
Oh, can you hear me?
Yes, I can hear you.
I think we may have lost
Daktari's side, eh?
Yeah.
You can probably share her slide still where she had gotten to, so that she stops sharing her slide, eh?
Okay, I could do that.
And she could probably switch her video, so for better connectivity.
Yeah, it looks like she's completely dropped off.
Okay, she'll be back to that soon. Let's hope for that.
Okay, we can give her a few minutes. Yeah.
Okay. In the meantime, esteemed members, esteemed attendees of this wonderful webcast for today, kindly post your questions. Keep your questions coming on the Q&A tab. They will be responded to after the final presentation. Kindly keep your questions coming on the Q&A tab. They will be responded to at the end of this presentation. Let's await Daktari to rejoin. Daktari, are you able to check on her? Check up on her, Daktari?
Yeah. Let me just try call her, see if she can.
Okay. Just let her know she can switch off her video for internet stability.
Okay.
In the meantime, ladies and gentlemen, and our distinguished attendees for tonight, you are reminded that kindly subscribe to this event on the PPB portal. The CPD points shall be sent 2 weeks from that date. Also, I want to remind you that this webcast is being recorded. it shall be broadcasted on the PSK's official page, that is Pharmaceutical Society of Kenya, on YouTube. Go subscribe to the page. You'll be able to be getting all our presentations, and also the presentations shall be uploaded. If you want all these presentations, they're usually uploaded on the PSK website, www.psk.or.ke/downloads. You'll be able to access them from there. So as we wait for our panelists to be back, kindly ensure that you subscribe to the event on the PPP portal, and also keep your questions posted on the Q&A tab. Dr. Miriam, are you able to get her?
Yeah, I'm still trying to reach her. Maybe if she doesn't connect in the next 1 minute, we can have Anthony do his presentation.
Okay.
Yeah, just to give her enough time to log back in.
Okay.
Okay, then, ladies and gentlemen, sorry for that small technical hitch. We seem to have had Dr. disconnected from this presentation, unfortunately, but we will have her back. But in the meanwhile, I want to perhaps give the floor to Anthony, who is my colleague at Novo Nordisk, to do his presentation. And then once Dr. is back, we would be happy to have her finish last few slides which were remaining. Welcome, Anthony.
Thank you so much, Dr. Biko, for the kind presentation. Also, I would like to take this opportunity to welcome all the PSK members. And shortly, I'll be sharing my screen. Kindly, Dr. William, let me know once you see it. For the sake of for connectivity, I'll switch off my video, but during the Q&A session, I'll put it on so that then we can address any questions that would be arising. Kindly let me know once you see my screen.
I think it's still loading. We're still not seeing it. Okay. Yep, we can see your screen. Thanks, Anthony.
Thank you so much, Dr. for that. And in a few minutes, I would like to discuss the role of insulin in improving the quality of life. And by the quality of life, what do I mean? I mean a life that is free of complications. And if our patients can live a life free of complications, then it means there will be maximum output at the work of their place. And also they'll have more time with their family. So once again, I'm Anthony Diongo, and I work with Novo Nordisk. Let's have a glance at who Novo Nordisk is. And we are a global healthcare company, which was founded in 1923 and headquartered just outside Copenhagen, that is in Denmark. What does this mean to your practice? What does it mean to your patients? This means that anytime you give a Novo Nordisk product, you're giving a quality product that has been tested and tried over the years. What's our purpose as a company? Our purpose is to drive change to defeat diabetes and other serious chronic diseases, such as obesity, rare blood and rare endocrine diseases. How do we do this? We do this by pioneering scientific breakthrough, expanding access to our medicines, and working to prevent and ultimately cure the disease that we treat. Day in, day out in our practice, we come across different patient profiles. And just to give us a flashback, I would like us to meet Mr. A, who is a 52-year-old man and has been living with diabetes for the last 8 years. His HbA1c is 8.5%, and for his lifestyle, he lands a busy shop. We can say that Mr. A is learned, and it seems that the shop that he lands is not bringing enough income, because we can see that he has a low income. He's on current medication, which is Metformin, 800 milligrams, which is taking twice with meals, and also Glybenclaramide, 10 milligrams, which he's taking twice also. What do we see from this case, pointed case in scenario? One, we see that there is uncontrolled HbA1c. Because what you can see from this is that he has a HbA1c of 8.5%. And from the IDF guideline, as Dr. has shared, is that it should be less than 7%. And this is despite intensification with Glybenclaramide from an OD to a BD dosage. What do we get from this? One thing that we can see from this is that definitely there is delayed insulin initiation. And this, if it persists, chances are there will be development of long-term complications. With that said, then it's very important for us to look at the impact of diabetes in our clinical setup. And what we can see is that there is an increase in cardiovascular diseases to a 2 to 4-fold when diabetes is present. Let's just look back and look at our renal units. How many patients lines in that unit waiting for dialysis? How much does a dialysis session cost? How much session do they need in a week? The cost may be around 20,000. How many sessions do they need in a week? Maybe 3. And that will bring the total cost in a week to around 60,000. In a month, we multiply by 4, which gives us around 240,000. So you can imagine the impact that our patients will have. And this is just dialysis without talking about other complications. Let's also look at the visual impairment, which may lead to blindness. We can take a pointing example of a middle-aged man who is a retiree, a teacher. And maybe after retiring, the only money that he gets is the pension. How much is pension? And with blindness setting in, it will mean that you'll need a caregiver. Not to mention about the lower extremity amputations. So we can imagine all these complications to the impact it will have to the quality of life and also to the well-being of these particular patients. So we really need to look at diabetes at a bigger image and just look at how much the complications can impact on our patients. Dr. has very well explained, and with this, also we have seen that in the pointing case of Mr. A, definitely there is a delay in insulin initiation. So do we really have a solution for this? Yes, we do. Because what we can see from this extract from Nathan et al. Is that insulin is the most effective anti-diabetic agent. And compared to all the oral antiglycemics, we can see that if we are to bring HbA1c down, if we are to reduce the HbA1c percentage, then insulin will do the job for us. What options do we have from Novo Nordisk? And with this, I would like us to know that we have a whole range of products from Novo Nordisk. We have a premix or a biphasic insulin going by the name of Mixtard. We have a basal or isoflavone insulin by the name of Selector, and also we have a fast-acting or the soluble insulin going by the name of Actrapid. And shortly, we'll see the action profile and how we can initiate with either of these insulins. Let's look at Actrapid, which is a fast-acting insulin. And what we notice is that the world's most used bolus human insulin. It can be used together with a basal insulin, which is insulated, and also the it has a fast onset of action, which is within 30 minutes. And with that, we can see from this profile. And from this, I'd like us to pay attention to the three parameters. That's the onset of action, the peak concentration, and also the duration of action. So for the onset of action, for act rapid is 30 minutes. And what this means is that when it's administered through the subcutaneous route, it takes approximately 30 minutes to bring down the sugar. How important it is to a patient? This is very important because we need to advise them that they need to inject 30 minutes before they take their meals. It peaks within 1 to 3.5 hours, and it have a duration of action of up to 8 hours. And what happens is that in case the glycemic targets are not met with a basal or the biphasic insulin, we can intensify with that rapid. Also, let us look at the at Insulatard, and this is the basal insulin, and also it's the world most used basal human insulin. It provides a long-lasting glucose control, and as we have seen from the guidelines, that as early insulin use is recommended by the EASD and also the ADA. I also want us to look at how to initiate with Insulatard. And before we go to the initiation, let us just look at the action profile of Insulatard. So once again, we look at the onset of action, which is 1.5 hours. The peak concentration, which is between 4 and 12 hours. And it has a duration of action up to 24 hours. How do we initiate with Insulatard? So with Insulatard, the guidelines or the insulin requirement is 0.2 international units per kg. And what we can see is that, or if you take an example of a patient who weighs 48 kgs, then we multiply by 0.2, which will give us an average of around 12 units, but we can initiate with around 10 units. Also, let's look at insulin and what, at Mixtard, and what it says is that when it's time for insulin, then it's time for Mixtard 30. And why so? This is because Mixtard is the world's most used human insulin. Also because Mixtard is a premix insulin for both the fasting and the postprandial glucose. And also, I would like us just to look at how we can initiate with Mixtard. And one thing you'll note is that it's very simple to start as a once daily injection. And as more control is required, then we can adjust to allow for a twice daily injection. To note is that Mixtard comes in two forms. We have it in form of a vial, which is 10 ml. And also we have it in form of a flex pen, which is a pre-filled pen, and I'll explain in details. Once again, let us look at the onset of action, the peak concentration, and also the duration of action of Mixtard. The onset of action of Mixtard is 30 minutes. And therefore, we need to advise our patient that they need to inject 30 minutes before meals. It peaks within 2 to 8 hours. And this means that we need also to advise our patient on snacking, and that's for healthy snacking to avoid cases of hypoglycemia. And that's why we say diabetes is a multidisciplinary disease. Because with this, then we need to work very closely with a nutritionist to guide our patients on healthy snacking. And what we can see is that have a duration of action up to 24 hours. As I said earlier, we need to, it's very simple to initiate on insulin, because all you need to do is to calculate the total daily dose of insulin. The insulin requirement is between 0.3 to 1 international unit per kilogram per day. And with this, we can do an exercise of just seeing how many units a patient can be initiated on. We can take an example of a patient who is 90 kgs. So we'll initiate with the lowest dose or the lowest requirement, which is 0.3, because also we don't want to expose our patient into hypoglycemia. So we'll take 90 kgs. We multiply by the units, which is 0.3, and that will give us 27 international units. If you are to give once per day, that is when the units are below 20 units, you give the total daily dose 30 minutes before a meal. When it exceeds 20 units, then we need to split that dose into two, whereby you give 2/3. You give 2/3 in the morning and 1/3 in the evening just before dinner. For a point in case of a patient who weighs 90 kgs, we have seen the total daily dose is 27 units. So to get the morning dose, we take 2/3 of 27, which gives us 18 units. So that's what we'll give in the morning. Then in the evening, we'll take 1/3 of the 27 units, which gives us 9 units. And that's the units that our patient will inject in the evening. So assuming we give our patient the 18 units and the 9 units, but every time our patient comes to the clinic, we find that there is some problems with the morning units. So do we need to alter the whole regimen, or do we need to titrate the whole total daily dose? We have a solution for you. So in case there is a problem with the morning dose, then you need to titrate the evening dose. And in case you have issues with the evening dose, then you need to titrate the morning dose. What happens in case someone was on another insulin and you want to switch to Mixtard 30? So in this case, you take the current daily dose and split it. 2/3 in the morning and 1/3 at night. And once again, kindly, let's remember to advise our patients that they need to inject 30 minutes. 30 minutes before a meal. Is Mixtard available, and in what form? Yes, it's available. And it's available in form of a vial, which comes in 10 ml, and also in form of a pen, what we call the Mixtard Flex pen, which is a pre-filled pen. These drugs are available both in cancer, for those who work for the public institutions, and also in meds, for those working in the faith-based organizations. Also for those in private practice, the drug is available from the major distributors and also from Philips. We have seen our case, our pointing case, where our Mr. H has 2 oral anti-diabetic agents. But what we have seen from that case is that the HbA1c is still high of 8.5%, and this is versus the IDF recommendation of less than 7%. So in this pointing case, definitely the oral anti-diabetic agents need help. And for that, the remedy for that is to issue or to give Mixtard 30 Flex pen. And why so? We have seen the importance of that is due to the address of both the fasting plasma glucose and also the postprandial glucose. Also, we have seen to initiate with insulin, how simple it is, with Mixtard, how simple it is. And also, as I urged earlier, kindly always remember to advise our patients to inject 30 minutes before a meal. We have seen mixed studies available in form of a vial, which comes in 10 ml, and also in form of a pen, which is a pre-filled pen. So why the pen? Why give patients the pen? We can see an illustration of the pen, and I'll walk you through. So we have the outer cap, which is which all you need is to pull it out. And once you pull, then you expose the cartridge, which at the tip is a rubber membrane. And this is where you attach the needle, either novel twist needle or novel fine needle. The cartridge has a residual scale, and this is very important for our patients. And this helps them monitor the units or the doses that are remaining. If you walk, or if you go to our extreme right, we can see there is a pointer, the white marker, and this helps our patient get accurate doses. As you know, with insulin, accuracy is of utmost importance, because if our patient overdoses, chances of going into hypoglycemia is amplified. If our patient underdoses, then it means they'll be in a state of hyperglycemia. And we have seen the complications that can set in if they persist for a long time in that condition. There is a dose selector, and the dose selector goes up to 60 units. Also very important is that as we use the dose selector, there are those tactile sounds, and they're in increment of our unit. We can see how the needle is. We have a bigger outer cup. We have an inner cup, that's the needle, and we have a protective tab which protects the needle from any contamination. So also, just to reiterate on this, is that the beauty about the pen is that it just allows us to select what is remaining in our cartridge, in our reservoir. So for example, if the insulin that remains is that units, and we want to inject 50 units, it can't go to 50. So it will just select what is remaining at the cartridge. Also, if you wanted 10 units and we end up dialing 15 units, we can always go back to the intended 10 units without wastage of our insulin. Our pens are color-coded, and this helps those patients using more than one pen to distinguish between them. Also, the force that is required to push is very low. And as you know, with complications of neuropathy, then this is very important for our patient. As I said earlier, is that accuracy is of utmost importance, and with a pen, that is assured. How easy is it to use the pen? It's very easy, actually, because all you need is to dial and inject. You just dial and inject. And what does it offer your patients? One is about accuracy. Two, about convenience. And these are priced more when doing injections in a public place. Take, for example, a person or a patient in a social gathering, be it a class, be it a baraza, be it on the waiting line to see the doctor. We know they're using mixed twice daily, and they need to inject their evening dose. How easy will that be while using a vial and a syringe? With a pen, the convenience and discreet is assured for that particular patient. As you have seen also, it's very easy to use the pen, and also the dose force that is required is very low. And with all those benefits, that's why we are saying, give your patients the power of freedom. And with this, we have patients that can really or fully benefit from the pen. We are talking about patients who are visually impaired. We are talking about the elderly, who dialing 10 units from the vial and syringe might be a problem. We are talking about our children, and also people who are in or leads very social lives. And by choosing the flex pen, it gives our patient all these benefits in terms of improvement of glycemic control, improved adherence to the medication, and also improved safety due to less incidences of hypoglycemia. How do you use the flex pen? For Mixtard, we have seen that it's composed of two components. We have the fast acting, and also we have the NPH of the basal insulin. So for that, we need to suspend our insulin to make sure that it's homogeneous. Then we attach the needle. Once we attach the needle, then we need to make sure that our pen is working properly, what we call priming. And with this, we just need to select 2 units and push the push button until some drops of insulin comes at the tip of the needle. From there, we saw the dose selector. So you select the units. For example, a patient who weighs 90 kgs, if it's the morning, you will select 18 units, and then you administer. For the site of injection, abdominal would be the most ideal, especially for self-injection, but also you could inject at the thigh, the upper arm, or the gluteal. Very important for us to make sure that the potency of insulin is maintained. And with that, we need to just look at how to store our insulin. But then why is this important? This is to ensure that fitness of our insulin as they're being used by the patient, also ensures stability of our insulin. We know insulin is a protein, so we want to avoid denaturing or spoiling. And also, most important is to ensure effective control of our blood glucose levels. Question has arisen on how we can store our insulin at our facility, and also when the patient is using the insulin at home. So us as a facility, us as an institution, we can store our insulin out of the fridge. So at all times, it should be in the fridge and a temperature range between 2 to 8 degrees. Yeah. So that's the place, and that's where we need to store our insulin. When it's in use, when the patient is using the insulin, then it can be stored out of the fridge for a period of 30 days. So we have the vial and we have the flex pen. So the duration is 30 days. But for the vial, the temperature should not exceed 25 degrees. For the flex pen, it should not exceed 30 degrees. And if we store insulin in those conditions, then we'll be assured that it will be stable and it will control the glucose levels as required. So thank you so much for your time, and I'll give back to Dr. William.
Thank you so much, Anthony, for the presentation. I think it was very comprehensive. I'll just hand it to Dr. Nduku, who will just finish the last few slides she has before jumping into the questions, which I see are already coming in hard and fast. Back to you, Dr.
Okay, thank you, Anthony. I trust you can hear me.
Yes, we can.
Yes, Dr.
Okay, so as Anthony has very well discussed, insulin therapy has a big role for all our patients, both with type 1 and type 2 diabetes. Particularly for type 2 diabetes, we agree that patients who have marked symptoms of hyperglycemia, such as polyuria, polydipsia, infections, or have complications from the diabetes, such as acute myocardial infarction, acute complications such as DKA, would definitely benefit from insulin. Those whose HbA1c are markedly elevated, above 9%, are having postprandial sugars of above 16 and fasting sugars of above 13, or unsatisfactory glycemic control on optimal doses of at least 2 agents, definitely would warrant insulin. From the previous slides, we saw that the earlier we start insulin, the better in terms of averting complications from the diabetes. So this is seen in major guidelines. This is from the ADA ESD position statement, which is reiterating the same thing for particularly those who have elevated A1C 2% above our target. Insulin would definitely be the way to go. So as a broad overview, as we've looked at previously, the various therapy options that are available for management of diabetes. This is particularly for type 2 diabetes. I'm sharing an expert from the ADA guidelines 2021. Metformin remains first line. From then on, we look at whether the patient has any complications from the diabetes, such as atherosclerotic cardiovascular disease or chronic kidney disease or heart failure, in which case the newer agents, such as the GLP-1 agonists, would have a role. In the absence of that, we would use looking at the compelling indications, like whether there is hypoglycemia or weight is an issue or cost is an issue, a selection of any of the other classes that we've looked at. So this is again emphasizing the same thing. Broadly, lifestyle and metformin are first. On top of that, we would try to attain target depending on the emphasis on whatever complications the patient may be having. And for those who have had atherosclerotic cardiovascular disease, such as myocardial infarction or ischemic stroke, there is definitely a role for the newer agents such as the GLP-1 receptor agonists, as well as the Sglt2 inhibitors. For those who have heart failure or chronic kidney disease, from the cardiovascular outcome trials, there is a strong evidence for using the Sglt2 inhibitors for this particular group of patients. As Anthony took us through, the target for majority of our patients is a glycated hemoglobin below 7%. That means our fasting sugars should be between 4 and 7, even as we are initiating these patients on insulin, and targeting our postprandial sugars at between 5 and 10. For the younger patient who has no complications, we can tighten the control to below 6.5%. Yeah, so in summary, as we have broadly discussed, our goals for this patient is to reduce the HbA1c to target. For those who have an indication for insulin, as discussed, insulin initiation is recommended. And for those who have compelling indications for any of the newer agents, such as Sglt2 inhibitors, GLP-1 receptor agonists, definitely those are the drugs we should be using. However, metformin as well as lifestyle therapy remain first line. Over to you, William.
Thank you, Dr. I think we'll just jump quickly to the questions, which are already flowing in. And the first question was from Edna Kubai, who, first of all, thanks you for the presentation. And then she comments that there has been a removal of Glybenclaramide from the KEML due to hypoglycemia and advocacy. What are your thoughts?
Okay, thank you so much, Edna. This is a big challenge. Many of our patients are on Glybenclaramide. However, we do agree that there are agents that are still sulfonylureas that may have a better safety profile, particularly for gliclazide, which may be available as MR, and also to some extent the others such as glimepiride and glipizide. So this is not something that would happen as an instant, because there are many patients who are on Glybenclaramide. It is something that we recommend that would be a transition, because as much as we are concerned about the risk of hypoglycemia, we also want the patients to be able to attain target and be able to afford the therapy that they are on. Yeah, so this is, it goes both two ways, minimizing hypoglycemia, but also ensuring that the patient remains on treatment. There are many patients who may have a challenge affording the other sulfonylureas. So for that particular patient, education would be key on how to prevent hypoglycemia, even when they are on Glybenclaramide, and where it is possible, transitioning them to the agents that would have a better safety profile. But cost, yeah, cost is an issue, definitely.
Thank you for that, Dr. The next question is, what is the best drug to use with metformin and insulin?
So the question is, what is the best drug to use with metformin and insulin? So metformin remains first line across most major guidelines. If the patient has an indication for starting insulin, these are patients who are coming in, which is actually many of our patients at the acute diagnosis of diabetes. Perhaps they have had an acute admission with DKA or a hyperosmolar hyperglycemic state. Many of our patients come in like that. Or perhaps they are markedly hyperglycemic. Their HbA1cs are 9% and above that, coming in with random sugars that are exceeding 16, fastings exceeding 13, are polyuric, they are catabolic. Many of our patients do fit their profile for commencing on insulin. For that kind of patient, if you're going the insulin route, insulin and metformin, when optimized adequately, can be able to attain target with the doses that Anthony has already discussed. So targets can be attained even with insulin escalated to metformin, because the options for insulin are many. We've talked about escalating. You can, if you're using premixed, you can go up from once a day to twice a day, depending on how the fasting as well as the prandial sugars are going. So this can be escalated to attain the HbA1c targets that are required. I'm hoping I've been able to answer that.
Okay, thank you, Dr. And the other question I see being asked by Maureen, is it okay to combine metformin and Glybenclaramide, and what's the benefit if there's any?
So thank you, Maureen, for your question. Metformin has been a first line across our major guidelines. And for many patients, especially if the HbA1c is 1.5% and higher above targets, you definitely will need another agent to combine together with metformin. So the selection of a sulfonylurea together with metformin, such as now Glybenclaramide plus metformin, definitely is a combination that many patients are on. The benefit would be that, for instance, metformin doesn't increase weight. It is weight neutral to slightly weight reducing. So it may offset some of the weight gain that you see with Glybenclaramide. It may also allow you to attain target without going to the much higher doses of Glybenclaramide, so reducing the risk of hypoglycemia for that particular patient. So definitely that is a combination that is used quite often, especially where cost is an issue.
Okay, thank you, Dr.
Yeah, thanks, Maureen. Yeah.
Great. We have a few product questions as we wait for other questions to come up. Maybe Anthony can answer some, and Dr. feel free to also join in.
Okay, thank you.
Michael asks, why do we need to give, let's say, insulin like mixed at 30 minutes before a meal?
Yeah, thank you for that very nice question. And yes, it's recommended that it should be all mixed and should be given 30 minutes before meals. As we know, is that insulin, especially at home, should be done through the subcutaneous route. And when done through the subcutaneous route, there is formation of the dimers and the hexamers, which are not absorbable. And hence, they need to be converted to monomers, which are absorbable. So the time drag between or the conversion of dimers and hexamer to monomers takes an average of 30 minutes. And that's why we say insulin or mixed that should be injected 30 minutes before meals. Yeah.
Okay, thank you. And the other question asks, how often should patients change the Novofine needle?
Very nice question also there. If you have seen the needles, be it the Novofine needle or the Novotwist needle, is that you have noted they are very fine. They are very they are very fine, and they come in a gauge of 32, and just 4 millimeters and 5 millimeters for the Novofine and the Novotwist, respectively. So what happens is that after subsequent injections, the needle blunts. And if it blunts, then it means the injection will be painful. And also chances of lipodystrophy, that is a infection at the site of injection, will be amplified. So to make sure that one, the Novotwist or the Novofine offers you painless injection, and also to make sure that there is no infection at the site of injection, then we need to change the needle. So that means then it needs to be a once-time use. Thank you.
Okay, thank you for that. Now, maybe I think one of the last, maybe the last two questions I'm seeing here, one, and maybe we can route this now to Daktari. Can insulin be administered IV? That's one from Evans. And then another question actually asks if the dose of Mixtard needs to be changed if someone is, let's say, having a night shift. Supposing a patient is on night shift, does the dosing of Mixtard change? That's from Ankileu. So does dosing change depending on the shift? Someone is working night shift, and maybe this question is aimed at perhaps teasing out if hypoglycemia is an issue. And then the other one is, can insulin be given IV?
Thank you, Evans, for your question. There are situations where we use insulin intravenously. For patients who come in with acute diabetes emergencies, such as diabetic ketoacidosis, we use insulin intravenously, usually for the first 24 to 48 hours, until the patient is out of the acute emergency. And then we are able to transition that kind of patient to subcutaneous insulin again. So a lot of the times in a hospital setup with acute diabetic emergencies, insulin is used intravenously. About the second question from Anne regarding the dosage of Mixtard for a patient who does night shift. For someone who is not sleeping at night, who is awake and active at night, I agree the risk of hypoglycemia, especially if they are active, may be an issue. The other concern is if they are awake at night, the meals may be predominantly more at night than what you'd have expected, where they are not eating because they are sleeping. So you might find that the dosing, both the morning and evening, may not be the standard 2/3, 1/3, depending on their sugar pattern. It may definitely need to be adjusted such that if they are getting hyperglycemia because they are awake and feeling more because they're doing a night shift, the evening dose may be even half of their total daily dose. However, if they are getting hypoglycemia because of excessive activity at night, we can come down on the doses so that it would be less than the standard 1/3 in the evening. I hope I have answered your question.
Yeah. Thank you so much, Dr. Nduku. I think that was the last question we have had. Thank you so much for all the presentations that you've made. Very, very clear. And I think for judging from the comments, many people who attended today's session would want to get the presentations in order to continue learning.
Okay, thank you.
Thank you so much, Daktari. And thank you so much, Anthony, too, for the presentation. Maybe at this point in time, I'll just hand the program over back to Mr. Mbao for a conclusion.
Asante sana, William. Dr. William, asante sana, Dr. Nduku. Thank you very much, Anthony, for your wonderful presentation and taking our participants through the Q&A. From PSK, I can see one of the chairperson for PSK South Rift Branch, Dr. Anthony Yaile is here. From the National Executive Council, Dr. Louis Mashogu, the President, the CEO, Dr. Daniela Munene, and the Honorable Fellows. We say thank you for honoring and being able to make your time to be with us this evening. For our members and all esteemed attendees, I want to remind you that tomorrow we are having another series. This time it's hosted by Hopak. Anthony, am I in order with that? Anthony? Okay, we're having another webinar.
Okay, go on, Mr. Mbao.
Yes, we're having another webinar by Novo Nordisk with the Hopak tomorrow. So kindly look out on your WhatsApp groups on the social media pages, so that we're able to join in. For tomorrow from 7 p.m. In another announcement is that on Friday, we are going to be having our annual general meeting that is for Pharmaceutical Society of Kenya members. Kindly ensure that you have registered by Thursday. Thursday is the last day of registration. So without further much ado, ladies and gentlemen, I want to call it a day. Swahili nasema lilo na mwanzo lazima liwe na mwisho, na yangu ni kuambia kwamba somo la leo litaweza kuwa katika tovuti yetu www.psk.or.ke/downloads. This presentation shall be uploaded on our website, and also this recording shall be shared on our YouTube page, which is the Pharmaceutical Society of Kenya. Kindly subscribe to the page so that once it's uploaded, you're able to see it. Have a good night and God bless you. Alamsiki.
Thank you and good night to everyone.
Thanks, good night.
Okay, thank you.